All right, well, hello and welcome to the Veteran Innovation Series. My name is Chelsea Burke, and I'm the Director of Iowa Veteran Education, Transition, and Support at the University of Iowa. We are thrilled to have you joining us to support the excellent work that members of the veteran and military connected community are achieving both at the University of Iowa and around the world. The Veteran Innovation Series brings veterans who are some of the most successful innovators in their field to the University of Iowa to build connections with our graduate and professional students and to provide UI graduate and professional student veterans with the opportunity to share their experiences and their expertise. Speakers share stories of innovations, creativity, and problem solving, helping us reimagine what it means to be a military veteran in the 21st century. Dr. Trill Paulin kicked off our very first Veteran Innovation Series lecture in March. You can watch her entertaining and inspiring lecture on our website, which I'll put a link to in the chat. And I wanted to thank the Graduate College, the Tippie College of Business, the Department of Anatomy and Cell Biology in Carver College of Medicine, and the Office of the Vice President for Research for their generous support of this spring's events. A few housekeeping notes. During the lecture portion of the event, audience members will be muted. We will turn your microphones back on for the Q&A portion following the lectures, during which you may ask questions by using the raise your hand function or by entering them into the chat. Jake Shillow and I will moderate the chat throughout, so if you have any technical issues, Jake and I are the ones to contact. Thank you to everyone once again for supporting our veteran and military connected community. Jake Shillow will now introduce our first speaker.
So thank you, Chelsea. Today I have the honor of introducing two incredible military veterans, Bob Wiederien and Ryan Rosell, who are currently pursuing advanced training programs at Iowa. They come from very different backgrounds with very different careers, yet their service to their community has taken them around the globe, sometimes to the same location. Now, today we are privileged to have them here at Iowa. And our first speaker of the day is Dr. Bob Wiederien, a physical therapist with an extensive military service and continued commitment to his community and the pursuit of knowledge to better treat patients. So Bob, the show is yours.
Thank you. Let me share my screen here. So today, I hope to take you on a journey through being a Navy veteran and now being an Iowa Hawkeye pursuing advanced education. I'll introduce myself with a little more background than what Jake was able to provide there. I'll give a little bit of an overview of my Navy career from a 50,000-foot perspective. Then I'll go on to talk about what led me to the University of Iowa, my program of study. I'll talk about my research area with visual feedback and virtual reality with physical therapy, and then where I go from here. And please hold your questions to the end between 5 and 5:30 after Ryan's had a chance to talk. So a little humor to get us started. On the left, you see what virtual reality is supposed to be like. And on the right, you see what virtual reality is like. All the chords and tangles and nuances of running a virtual reality system. So as I was introduced, my name is Bob Wiederien. I'm a physical therapist. I have my Doctor of Physical Therapy degree. I'm a sports certified specialist by the American Board of Physical Therapy Specialties. And I'm currently a PhD student in Rehabilitation Science at the University of Iowa. I'm a retired US Navy physical therapist, and I'll go into more of my Navy career here in a minute. I did also 2 years of civilian physical therapy practice in outpatient orthopedic and sports physical therapy down in Mississippi after I retired from the Navy and before transitioning back up to Iowa. I have multiple specialty certifications in dry needling, functional movement screening, selective functional movement assessment. I'm an emergency medical responder. I have many other certifications that are clinical that are behind my name. Too many to list. So I spent 20 years active duty in the Navy. My job there was a physical therapist. And I was able to do that through a lot of educational opportunities that I took advantage of. First off, I started my Navy career at the Army Baylor doctoral program in physical therapy, where it at that point in time was a master's degree program. Now it is a doctorate degree program. So this gave me an opportunity to actually attend physical therapy school while I was active duty. Wearing the uniform and going to school every day was no joke. It was like drinking out of a fire hose. Every chance that I got, I was able to learn more information and take in more knowledge and increase my skills. I then went back to Baylor University in 2007 and earned my Doctor of Physical Therapy degree. This happened while I was deployed on the USS Nimitz. Moving on to the next educational opportunity, I'm now at the University of Iowa here, like I said, getting my PhD in rehab science using my GI Bill. So if I were to give any advice to any veterans that are out there, it's to take advantage of the educational opportunities that the military can provide you. Some of my Navy career highlights is that I was at 9 different duty stations, scattered around the world, 6 different moves. Started at Fort Sam Houston in San Antonio, where the Army Baylor program is located at. From there, we moved on to Okinawa, Japan, then to Hawaii, San Diego, California, Virginia Beach, and Portsmouth, Virginia, and then Gulfport, Mississippi, where I ended my Navy career. Some of my experiences was that I was originally and initially in pediatrics. And from there, I moved on to outpatient orthopedic and sports physical therapy. I did some time as a spine specialist, and I even did some time as an inpatient physical therapist. Some of the different assignments that not many military people can say that they've done is served on board a USS aircraft carrier. I was on the Nimitz CVN 68 for 2 years. I did 2 deployments while I was on there. One was to the Persian Gulf and one was to the Western Pacific. I also did a tour with Navy Special Warfare. And at that location, I was working with Navy SEALs and Navy SWCS, the Special Warfare Combatant Craft Crewmen. They worked together with the SEALs to provide Navy Special Warfare. I also worked with the Navy Seabees, the construction battalion personnel, down in Gulfport, Mississippi. That's where I ended that part of my Navy career. Besides being a physical therapist, there's a lot of leadership opportunities in the Navy, in the military. So while I was at Navy Medical Center Portsmouth, which is one of the largest hospitals in the Navy, I was assistant department head. Down in Mississippi at Navy Branch Health Clinic Gulfport, I was the department head of the medical side of the house, where I supervised over 60 employees and had a budget over $1 million. So what is physical therapy like working with tactical athletes in special populations? Serving on board an aircraft carrier that's 3 football fields long and a football field wide is very arduous. There's a lot of long hours, underway time, as we say in the Navy, the deep water blue, or the deep blue water. These guys go out and gals go out on work on these aircraft every day, launching planes off the front of the ship and catching them off the back of the ship. While I was there, I saw a lot of different orthopedic and sports type injuries, things that not a typical physical therapist would see and be able to take care of, from fractures to sprained ankles to even a broken nose or two. Moving on to this Navy Special Warfare population, working with the Navy SWCC operators. These guys and gals go out at the tip of the spear, running small boat operations for the Navy. You can imagine taking the toll of going over some of these waves and riding some of these boats. There's a lot of compression type injuries that can occur. So while I was there, I saw a lot of spine injuries and neck injuries. The Navy Seabees, the construction battalion, their motto is can do. They like to build things, take care of things, and they're also out there in the fight on a regular daily basis. So they get beaten up and broken down pretty routinely as well. So working with physical therapy in all of these different settings and scenarios was challenging, to say the least. So why Iowa? Why, after moving around the globe, did I settle on Iowa? Well, first reason is that I'm an Iowa native. I was born and raised over in Carroll County in the western side of the state. We're probably all familiar with the Iowa quote from Field of Dreams, "Is this heaven?" It's Iowa. But seriously, one of the big reasons why I wanted to come to the University of Iowa for my PhD program is that the physical therapy program is ranked currently as #4 in the country in US News and World Report, which ranks all the physical therapy programs across the country. And it's consistently been in the top 5 to 10 over the past 25 years. They also have the PhD program in rehab science, which is what I'm in right now. And that PhD program has been going strong for many decades. I have the privilege of working with Dr. Jason Wilkin, who's a PhD, as my advisor and mentor. I met with Dr. Wilkin after he came to the University of Iowa and found out that he had done previous work at the Center for Intrepid, which is down at Fort Sam Houston, which is one of the hallmark centers for working with injured soldiers, sailors, airmen that sustain multiple combat casualties. While here at Iowa, there's the Human Performance and Clinical Outcomes Lab, which I'll go into detail here in a little bit. And I have access to the other outstanding physical therapy labs, as well as the other professors and the research that's done here at the University of Iowa. So one of the hallmarks of the Human Performance and Clinical Outcomes Lab is a virtual reality system that you see here pictured in the slide. It's got a 270-degree surrounding screen that takes up a good footprint of the floor space. It has a dual belted instrumented treadmill that can go in multiple different directions in terms of pitch and roll. And it's extremely useful in the virtual reality research that's done here. Another centerpiece of the Wilkin Lab is the overground walkway. So this is a walkway with 3 embedded force plates in the floor that can be used for assessing motion and gait mechanics as people are walking over ground on level surface and on a rocky terrain. There's 12 cameras that surround the walkway system, and the cameras pick up on small motion sensors that are attached to the skin in different locations. This allows us to track the person's movement as they walk across the walkway. And the force plates allow us to calculate forces going through the different joints of the body. So this is an overview of some of the rest of the lab. You can see in the middle of the screen on the left, 4 sensors that are the motion sensors that are attached to the skin for collecting the data over the walkway and in the virtual reality system. In the middle on the right is one of the cameras that pick up on those sensors. We also have in the bottom right, electromyography that can be attached to the skin. So these units pick up on the muscle activity that's going on and transmit the muscle activity wirelessly to the sensors and to the computer. We can also calculate plantar pressure by using these foot devices over on the left that are like a shoe insert, and they can pick up what's going on at the back of the foot, the front of the foot, and in the middle of the foot. All of these systems feed into a computer, and what you see on the left is the stick figure of the person that actually has the sensors attached to them and is walking over the overground walkway. After processing the data, then the stick figure that the computer can calculate with the motion capture system can be turned into a skeleton model, which will further enhance our ability to assess what's going on with the human body during gait, during walking. All of these systems are able to talk to each other, and it's pretty impressive what they can do. One of the interesting parts of working in the lab is carbon fiber orthotics. So as you see on the right, the carbon fiber prosthetics that an individual with amputations has sustained amputations has been given these prosthetic devices that are made out of carbon fiber, which can allow for return to sport, including running. Over on the left, you see that the carbon fiber has been developed into orthotic technology as well. And these orthotics can be used on people that have sustained injuries, but still have their limbs intact. The cool part about these carbon fiber devices is that they store energy and can return energy to propel the limb forward. This can enhance their ability to perform functional tasks, return to sport, return to activities that they otherwise wouldn't be able to do. So visual feedback, moving on, visual feedback has long been used in physical therapy. As you see over on the left, this is a person that has been being trained on the treadmill with a running gait using visual feedback. There's peaks and valleys of their running cycle, and they're being retrained to run with a lighter impact or with better mechanics. Over on the right, you see an individual that has sustained a transtibial amputation and is wearing a prosthetic device. So physical therapy, working with these individuals, has long used mirrors for helping to give them feedback. And now we can move on to where we're using computerized technology. Not only is it useful in runners, walkers, and people like that. But we're also using it for stroke patients. As you can see on the bottom right, the fitness and gaming .com has provided a picture there of an individual after a stroke being retrained on how to walk in a off the beaten path kind of environment. So visual feedback and gait with prosthetic and orthotics has led me to where I'm at now in my research. So currently I'm finishing a systematic review that will be submitted for publication. And in this systematic review, we found that there actually is not a lot of evidence out there in the literature already showing how visual feedback and gait is being used in the orthotic and prosthetic research. With the lab capabilities here at the University of Iowa with the virtual reality system, iPads, etc., and the camera system, there's almost limitless possibilities for working with visual feedback and gait and these orthotic prosthetic devices. This has led me to think about some different ideas that I could use as a dissertation project, which I haven't settled on yet because I'm still early in that part of my graduate career. What this will lead to is more research, clinical application, and improved functional outcomes for individuals in the community. So physical therapists will be able to use visual feedback as a tool to help improve and enhance their clinical skills and to enhance the person's outcome. So putting the pieces together, I bring to the table a lot of different physical therapy experiences that I've had based on my military career. So being a veteran of the Navy, I can use these experiences to launch me forward into the next stage. Combine that with a top-ranked PhD education here at the University of Iowa, along with quality research and the focus on visual feedback, virtual reality systems, gait, carbon fiber orthotics, and prosthetics. As well as being able to teach the future physical therapists. Part of my PhD program is that I'm involved in graduate research and graduate teaching experiences. All of this will lead to a community impact, being able to enhance the physical therapy that's being provided in the community, not only in the University of Iowa, but around Iowa, as well as throughout the nation and the world. Hope to be able to bring these experiences in education, research, and teaching all together into a nice, neat format. And how I got here is no surprise. I have a huge support system. My family, my wife of 23 years, and my 4 children. And then on the right, you see my parents and my brothers and sisters that have supported me throughout this education and throughout my Navy career. What you see here is the final piping ashore of the family. During my retirement ceremony, I was piped ashore, which is the Navy's way of saying goodbye and welcome to the next stage of your life. Thank you, everybody, for attending the lecture.
Bob, thank you very much for your really exciting talk. I have a list of questions, so I'm excited to get to those here in a little bit. So our next and final speaker of the day is going to be Dr. Ryan Rosell, who joins us from the world of dentistry. He's here at Iowa doing his specialty in endodontics. So Ryan, when you're ready, go ahead.
All right, give me a second here and we'll, all right. Everyone able to see that?
Yeah, it's good.
Yep, we're good to go. Okay, great. Good evening, everyone. My name's Ryan Rosell. Bob, that was a great presentation. Very interesting to see what you guys are working on in the PT department. So hopefully I can back that up with something as good. So what we're going to talk about today a little bit is what I like to call the road less traveled. But it seems like Bob did a similar road as well. So I felt since getting into dental school and that path that I've been pursuing really since I was a child, always wanting to move into the dental field, that once I was able to get an acceptance letter into a dental school, that the military was able to provide me some of the best opportunities that you'll find in America as far as pursuing a professional degree like that. So I was able to grow as a dentist and find out really more of what I was passionate about, not just the entire field of dentistry, but drill down in that. And also broaden my skill set and my understanding of things inside and outside of the field of dentistry. I got to do some pretty fun Army stuff. You'll see some pictures on that. And then not nearly as long of a career as Bob's was, but I did 6 years active duty. And after that, now I've left and come here to University of Iowa to pursue a specialty degree in endodontics. And we'll talk a little more about what that is. There's a lot of people out there. Many of my patients have no idea what the word endodontics are or is. So we'll kind of highlight a little bit what the basics are of that too, and then a little bit on my research. And I'd be remiss if I didn't talk a little bit about the military scholarship programs that made all this possible for me. I didn't come from a extremely wealthy family or anything, and I feel like that the military has a opportunity second to none for your average person to be able to pursue advanced degrees like this. So while the way this works is in the Army, Navy, Air Force, you're in dental school or a medical program, and the military has given you the opportunity to sign a contract as an officer, and in exchange for paying them back in years of service. Normally a 1-for-1 if you're able to sign that contract at the beginning, the onset of your professional degree. What I didn't realize, because you don't really have a lot of insight into what that career looks like before you join, is that I would be afforded some of the best opportunities with all facets of dentistry. And just like in medicine, there's just so much to know. It's impossible to be an expert in everything. So we have specialties just like any other profession. So I was surrounded on a daily basis. I shared offices with endodontists, pathologists, oral surgeons, periodontists, people with advanced general dentistry degrees, 2-year and 1-year programs, prosthodontists, orthodontists. And I would say in the private setting, that is exceedingly rare, especially in a case where all of you have a little bit of time in order to mentor the younger providers. So I'd say my first, well, really all 6 years I was serving, if I had a question, it wasn't call up one of the specialists and say, hey, can you see this for me? It was, hey, are you free the next half hour? Can you come by my operatory and teach me something about what I don't understand about this case? And you've got an expert in that very direct field able to give you great information on that. Also, I believe this is the same way in all branches. You're not worried about a dollar bottom line in military service. You're more concerned about providing high quality care and not doing everything possible to not do any harm to the patient. That's a very important thing in the military, is doing best evidence dentistry, as well as creating a very safe environment for all of our soldiers as far as providing care. So that was always a nice thing, that I didn't need to double, triple, quadruple book myself. I could care more about treating the patient that's in the chair at that time with whatever that was required before they were then sent off for deployment to do their job that they were brought into the military to do. Not only that, you're able to get out of the clinic and do physical fitness activities to stay at peak physical shape for when you do deploy or when you're asked to go abroad. Leadership courses outside of dentistry specifically, but in every profession there is a need for administrative tasks, leadership courses, and plenty of continuing education. Last week we were at what is called the AAE, the American Academy of Endodontic annual meeting, and there were a couple of Air Force endodontists that provided continuing education lectures that were very cutting edge, very informative and interesting. And those are types of things that we would get on a quarterly basis, especially if you're stationed abroad. So I always felt like we were well taken care of as far as being required to learn continuously. Here's just one example of some of the equipment that I would use on a regular basis while in the military clinic. That unit you're looking at to the back left of me, let's see if I can get a pointer here. Pointer options, laser pointer. So this this computer, it's a mobile computer that allows me to take intraoral images. Some of you in the audience might have had a crown created this way. This is some of our newest type of technology, where you take intraoral photos of the mouth, and then it populates that, and you're able to design on a tooth and a couple of different things. This really is expansive technology that you can do many things with, that even applies to endodontics. And right in front of the patient, I'm able to design them a crown and use a 3D model in order to print out the crown, fire it, and place in that patient's mouth in a couple of hours. And traditionally, that would be impossible. You would need to take physical impressions, send that to a lab, and get that back in, at best, a couple of weeks. And obviously, our population in the military with rapid deployments that's unacceptable for some patients. So to be able to get that to someone in a couple of hours was really invaluable. So this was a technology that I found very useful on a regular basis. Here's a picture that I definitely look back on fondly. We had service animals at my last duty station at Fort Shafter in Hawaii. And those service animals, as their working life comes towards a conclusion, their teeth wear down excessively, because how they immobilize their target is with their teeth. And so you're always training these animals and wearing their teeth down. So eventually, some of them need root canals. And I was fortunately positioned near that clinic, and with a desire for root canals and endodontics, that I was called upon to do root canals on these service dogs. And just an experience that I don't think many general dentists are able to get to do, but it was really rewarding to be able to help these service members out. Here's another type of training that we were able to do. This is a stock photo, but it gives a good overview of what this course was like. So called Combat Casualty Care Course. We called it C4, where you took, this is a mannequin, but it's a high-tech mannequin that has a pulse. You put a pulse oximeter on it, you can check oxygen levels, and then there's a computer screen that's going to be up off to your to the wall, to a side or another, and you add volumizers, and you can do a tracheotomy, you can do a cricotomy, ways to administer urgent care in what they call the golden hour, that first hour, in order to save a patient's life. And And yet, as a dentist, I was even allowed and needed to go to this course. It was 2 weeks long in order to be prepared if there ever was a mass casualty event while I was deployed, to be able to be useful to the military in that situation. Because at that point, you know, every body counts, every brain counts. So I look back on this course as if it was something that definitely would never have gotten if I just had done private practice post dental school. This too was another fun thing. I was attached to the U.S. military endurance sports team. I tried to get a slot on the all Army team, but was unsuccessful. There was just some amazing athletes out there. So these are just a couple of fun photos of some of the races that I got to take part in. Just good camaraderie, good hard work, and another course that really has absolutely nothing to do with with dentistry, but I felt the calling to go try and do these extra courses. This is the Savalowski Air Assault School. So this is where you learn a little bit about helicopters and fixed wing aircraft, and then mobile wing aircraft, and rappelling out of that. Something that I doubt I would ever use in real life, but you know, one of those really amazing experiences that, again, you would never find anywhere else. So now let's move on to what I'm doing now. So what is endodontics? Most of you probably know, but some of you definitely don't know. The tooth itself is multiple parts of one larger organ, and when you have insult to a tooth and bacteria that invades the pulp complex, that it's unable to fix itself. Sometimes it can create a dentinal bridge and repair itself, but if the decay is too extensive or bacteria infiltration is too extensive, you get what we call an infected tooth, a tooth that can't fix itself at this point and needs a root canal at best to save it, or needs to be extracted. This is where I come in. So real basic overview here. I would open the tooth up, clean out the site of the infection, the source of where the bacteria is inside the tooth. And research shows that if you're able to remove most of that bacteria and fill that space, then your body can do the rest and heal. And eventually, after putting a filling material over where I'd accessed, a filling material in the root space and a crown over the top of that tooth, you should get healing and you know, extended life out of that tooth. We kind of look at a 10-year survival rate or success rate as a success, but you can last anywhere many years beyond that. But the point of all this is to extend the life of your teeth. You know, at this point we're living 80, 90, 100 years, and personally I don't think that our teeth were designed to do that on their own. So thankfully we have dentistry and endodontics in order to get us through a entire life with a high quality of life and high quality ability to eat. Why does this specifically matter? You may have seen this before. This is something that I see on a weekly basis. We'll have a young kid or any age person come in and with a good sized swelling on their face. Not always this large, but definitely this is not something that I would be surprised to see. So you would have that infection that gets large enough, and you would have this thing called an acute apical abscess, where you've got a inflammatory reaction that is trying to fight this infection and it's losing. And so you get a large swelling in that general region of the mouth around that tooth that extends up into the eye sometimes. Sometimes it extends down below the mandible and into the neck. And it's something that we have to deal with urgently, or else you can have space infections or even the potential for death if the swelling gets too large. Dentistry as a whole is something that I have always kind of been intrigued with. My father was a remodel contractor, still is, but he's mostly retired at this point. But I grew up working on site with him, framing and pouring concrete and doing those kinds of things. And I always found it interesting once I got into dental school to learn the basic concepts, how similar they really are. So this picture is a good highlight of that. I always felt like, you know, my dad, with the ability of his hands, would have been a great dentist. He just had a great conceptual understanding of things that haven't been built yet. So what I'm constantly trying to do, as a dentist, if I was building a crown, I'm having to visualize what I want it to look like at the end and how it's going to function inside the mouth before it's there, and knowing what to remove and what to save, and then if that will work or not. In endodontics specifically, I'm having to visualize a lot of times if I'm not able to directly visualize with my eyes what's going on, by tactile sensation and by functionality. Endodontics specifically, I don't know if my program director would agree with me or not, but I've likened endodontics specifically. We use very small hand files in all our treatments that you use your tactile sensation of just your fingertips to feel how far down a canal you are, if there's blockages, if there's more canals that you can't see on a two-dimensional x-ray. And it's very, very minute movements that over time, hopefully, we're able to master, learn better in order to provide the best treatment. So I always kind of felt like not as cool, but being an endodontist is a little bit being like a safe cracker. You know, you could feel just tactily where that click was. Yeah. And of course, being in the field of dentistry or medicine or any field that deals with people, you can only be so good for a patient. You can only provide a certain level of quality of care if you aren't addressing the person as a whole, the person as an individual, because everybody comes to you uniquely, right? Everyone has a different personality, a different experience. While over time you might start catching patterns of a symptom, a history of symptoms, which of course we're taught, it doesn't make it all the same. You know, you can't put everyone into the same box. You can try and give evidence-based reasoning of why you're going to choose one method to treat a patient versus another, but there's a reason why we haven't gone to AI for diagnosis and treatment for the entire field of medicine, because just everyone does have is different, right? We're all unique. So because of that, I am very focused on the interaction I have with the patient in the chair, the person that I'm talking to, and their experience, how they're feeling, what they came in like, as much as, if not more than, the treatment I'm going to be providing them. Picking up on little cues, those types of things go a long way. Endodontics specifically, if everyone's heard the term root canal, and I doubt anyone has ever said to themselves, that sounds great. For the most part, people would be very apprehensive, afraid. It would be on the list of things that people would have anxiety over, very high up on that list. And research would show that if you're able to meet expectations or calm someone down, really is what I'm getting at, while providing that care, prior to providing that care, post-op pain, a patient's perception post-op is much better. And that just goes a long way in everything that we do, right? So talk a little bit about current innovations in endodontics. why the specialty is really exciting for me personally. So in recent history, microscopes, high magnification microscopes have become a standard of use in the specialty. All schools that have a specialty in endodontics are required to teach the use of microscopes for their care. And I would admit, prior to specializing in endodontics, I would perform this treatment without microscopes. And I kind of look back on that and wonder if I was able to provide the best possible care that was there. It really is this easy to see inside a tooth, and with the amount of light that you have, you're able to see very far down the canal space, depending on your access. And this isn't even the highest magnification. So when we're looking at the differences in magnification that we're able to see inside of a patient's mouth, if your dentist is working on you and they have these things called loupes, these microscopes that come off their eyes, you're looking at a range of 2 times magnification to 4 to 4.5, up to 5 times magnification. In this case, we're using anywhere between 5, 10 magnification to 30, 40, and 50 magnification. So the range is very drastic. And the ability to see the pulpal floor here with the knowledge that I'm gaining of general anatomy of what we call the pulpal floor here, I can have a good understanding of how many canals there likely is, if there are possible additional ramifications. So right here, I would assume that there's some excess tissue or something that might actually require widening this out, opening this up. And if it isn't opened up and explored, there's a potential to leave a unobturated or uncleaned extra canal there that could cause this root canal to fail. Because if we left bacteria in there excessively, then in a year or two, this patient might notice symptoms again, and we would have what we call a failure. So with a four times magnification, it'd be very, very difficult to see this and do the best possible care that's out there. Also, we're having a increase in potential materials that are showing promise. Research has been out for quite a while on MTA, mineral trioxide aggregate, as far as its ability to reintegrate attachment of bone between the root space and bone around it, as well as other materials that we don't have as much research on at this point, but seem to be fairly promising. And anytime we can have an increased success rate or healing rate with materials that we use, it's gladly welcome, because of course, as a profession, you're always looking for 100% success, 100% healing, which while is likely impossible in itself, the striving for near 100% is always the pursuit of every profession, right? Another innovation that we use extensively here at University of Iowa is cone beam computed tomography imaging. It's a 3D image this is an image of a full mouth CBCT. For the most part in endodontics, we'll take a smaller one that will highlight just a few teeth in that area, and then it gives us, as you can imagine, this in itself. Let's say this would be a single slice. When you take a periapical X-ray, the traditional 2-dimensional image, which we take many of during a single treatment, you only get so much information. But when you get the ability to look at 3-dimensionally around a tooth, you can get a better understanding of the number of canals, the number of roots, the angulation of those roots, the calcification of them versus the wideness of them, any pathology that might be around that area, which, of course, any additional information we can get, we take, because pain as a metric is very difficult to discern what the true problem is when someone's coming in, right? So any additional information we can get is extremely valuable for us in addressing that actual chief complaint of pain or swelling or something like that. Here's I'm just going to show a couple of slides of why all of these innovations are extremely important. This is a surgery that I did recently where we did a root end resection. Patient was having pain post a root canal that was done years prior, and there were some issues with it. So we tried to do a traditional retreatment where I went in through the top of the tooth. So you kind of see this this orange color here was me drilling down through the top of the tooth, and I was unable to navigate the entirety of that root. So we were looking at doing that from a surgical approach. So here's an image of me through a microscope looking at a osteotomy that I had done in order to expose the root tip, and we found a separated file that was in there from a previous root canal treatment that we hope, this is a little bit of granulomatous tissue from the persistent infection that was on that root post the original treatment. And this is me replacing the tissue after that when finished with the procedure. So here's a pre-op and a post-op. So we'd found this this file that was there, and as you can see, I went in laterally, created a window through the cortical plate, removed that section of root and closed it up, and then the expectation at this point is for over time this to heal up with new alveolar bone, and for this patient to get a number of years of continued use out of this tooth pain-free. Current research that I'm doing while in this residency, we have an expectation to perform research that helps the field in itself, and so the project that me and one of my colleagues have begun pursuing is one where we integrate cone beam computed tomography with the presentation of calcified teeth, extremely calcified teeth, that we would diagnose as something called canal obliteration or pulpal canal obliteration. Here's a two-dimensional image of what that might look like. This type of thing normally happens because of trauma in the anterior region. This is a premolar, so this is more posterior, but just a good representation of what that is. In the history of endodontics, there's very few studies on the long-term effects of having pulpal canal obliteration for it being such a relatively common presentation post-trauma. It happens over 50% of the time, depending on who you, what research you're reading or who you quote on that. But there are no studies currently on cone beam computed tomography use in looking at cases of pulpal canal obliteration. So that's what we're hoping to do, is look at cases that we've seen this calcification inside the root and see if there's any pathologic issues from a radiographic standpoint in the three-dimensional presentation. So we're excited to see what that shows us, if there's a change in our understanding or a change in the diagnosis that we would choose to do depending on that presentation. And like I said at the beginning of this, it would be inappropriate for me not to bring up how important these programs are that the military has and has afforded me to pursue things that I find just so interesting, so cutting edge. So this is the Health Profession Scholarship Program. A lot of you, if you're veterans in the audience, already know plenty about this in the GI Bill, but if there's anybody out there who's looking at a career and a future career potentially in medicine, this, I would say, hands down, is one of the best ways you could possibly do it. Some of the things might change, some of these numbers probably already have changed, but this is very similar to what I was afforded when I was at USC for dental school. They'll pay for 100% of your tuition, give you a sign-on bonus while you're in school, and as a 23-year-old who never made a dime prior to that, or summer jobs, not making much more than, I think it was $7 an hour at the time. That was quite a bit of money. They also cover all your books fees and medical school expenses, dental school expenses. And they also give you a small living stipend bill to pay for room and board in that area. You are asked to go on active duty for 45 days, depending on your program, if it's not year round. I wasn't able to do that active duty, but they still paid you for that because USC's dental school was a 12-month program per year. And then once you're done with that, you serve for 4 years. So to give you guys an idea of how massive this is, USC, where I graduated, I pulled this straight from the website, which means it's probably a year old and it's gone up a little bit since then. This is just the tuition cost, or your cost to attend the school. You're looking at almost $90,000. This is not living expenses, and it's in Los Angeles. So you're looking at upwards easily over $100,000 a year for 4 years, with a percent, a 7% interest rate on that. You're looking at over $500,000, which is very normal at this point for a lot of my colleagues who didn't have the ability to take on the scholarship through the military. And gosh, to say like that the military hasn't given enough already, they also gave me the GI Bill benefits for serving for 6 years. And you're not precluded from the GI Bill when you take the health profession scholarship. So after serving for those 6 years, I was still able to use the full GI benefit to be here now. And I'm raising a 7-month-old little boy, and I have a wife, and we're able to, without the fear of going into a large amount of debt, be able to come back and pursue a passion in specialty training. So I implore anyone who's looking at a way to make this financially viable as a career to look into the military. You don't have to go to any school. You can choose whatever school you want to go to, but I would say look into any state school. As an active duty person, you're allowed to go to any state school, even not as a resident, and get in-state tuition. And the GI Bill covers in-state tuition, which is a huge benefit. The Yellow Ribbon program specifically is like a matching program. So let's say there's an amount over the amount that they would cover you for tuition. Let's say it's 40,000, so you got 22 left, and the school will knock off 5K. Then the Yellow Ribbon program will knock off another 5K, and you'd only be on the hook for 12,000 a year. So again, a very huge benefit for all our veterans. And that is it. Thank you guys so much for listening. I appreciate your engagement, hopefully here in a second, but any questions?
Thank you
Ryan,
so
thank
much,
you.
Ryan. Jake,
Thanks,
you
Kelsey.
go.
I just wanted to say, I guess on behalf of us, Bob and Ryan, thank you for your military service, and then also your continued service to our communities. And I guess we're going to open this up for some questions now. And as a moderator, I'm going to steal the first question, which I had for Bob, which was, you had an extensive military career and you got your doctorate in physical therapy. What was the need to then go back to school? It seems like you've accomplished so much at this point. What does this allow you to do here in the future?
So this allows me in the future to do more research and more teaching of the physical therapists of the future, with the expectation that the entry-level physical therapy degree is now a doctoral degree. It takes the PhD world to be able to do the research and the education of those physical therapists to make sure that they're getting the quality that they need to advance our profession even further.
Thank you. So we have a question, 2 questions in the chat. We'll start with Ryan. So Damaris asks, I noticed your emphasis on interacting with your patients on their own unique experiences with a problem. As an Army medic veteran, they taught us pain is the patient's problem. Given your education and experience to provide knowledgeable and custom treatment to each individual, where did you pick up your bedside manner?
Okay, I'd say a couple of questions. I think I'll try and break it down a little bit. So it's definitely not natural. It's a learned thing. As far as I think you have to treat a lot, just as you were a medic. Your first patient as a medic, I'm sure your bedside manner was less than ideal, and I would say the same was probably for myself. It takes hundreds and thousands of patients, I think, just to understand the nuance of people having unique experiences and unique issues. Yeah, definitely a learned thing. As far as bedside manner goes, gosh, that's probably more personality than anything else. I get a lot of enjoyment of just being in congregation with people. So that just it's energy giving and life giving for me. So it just kind of goes hand in hand with the profession in itself.
That makes sense. Okay, we have another question from Damaris for Bob. So Bob, having a support system is evidently influential in one's personal success in achieving the career path they've set on. Besides the close ties to your family, is there anything else that you would attribute to motivating your success?
So I would say the mentors and the experienced physical therapists that I've worked with over the years have been a huge part of my success as well. Anytime you're in any sort of environment, whether it's civilian or military, you always have to look up towards a mentor and experienced people to help kind of lead you down a path. And I was fortunate to run across several very good mentors over the years that led me down this path.
Yeah, mentorship is huge. Jake, I'll let you read the next one.
So the next question is for Ryan. What is your anticipated observation of monitoring the calcification for extended time periods? So I guess getting to a more specific question.
Yeah, towards the research. So we have one article on pulp canal obliteration, specifically in their radiographic presentation of having infection, or we would call pathosis, specifically when you have a loss of bone around the root tip, you would call that a periapical radiolucency, which indicates either a cyst or an active infection, which happens around 8% of the time in cases of pulp canal obliteration. Unfortunately, that one study that was done back in the late 90s, I believe 97, was done with two-dimensional imaging. So as you can imagine, it doesn't give nearly the same quality image and the amount of data that you would like to have if you're going to have to assess something strictly on its radiopaque versus radiolucent presentation. I would say likely we're going to see a small uptick in presentation of disease or at least a loss of bone, and then I'll allow others in the field to postulate on what the reason of that is. But yeah, I would say we're probably going to see a little bit uptick in that.
Interesting. You mentioned a little bit earlier about the anxiety that people can have going into, say, a root canal, and how it's maybe kind of you're doing to calm their nerves, and then you showed us an image of a file that was broken off from a previous root canal. which I don't know then calmed my nerves about going into there. Right.
Well, I would say for the most part, broken instruments still heal. The infection in that area still heals. The idea of all root canals is to decrease the bacterial count inside. And if let's say you're doing treatment on a case that doesn't have a lot of bacteria in the root yet, for the most part, it'll heal. So it's I'd say a rarer thing to have a separate instrument have a failure the way it did. But as far as pain goes, you wouldn't even know. There's a lot of people who walk around with broken instruments in their tooth. Not a lot, but more have it than you probably expect, and fewer have issues with it than you would expect as well. Yeah. Okay. But yeah. We have something else here, huh? Academic and clinical requirements. Yeah, for the most part, we're clinical. I would say on a 5-day work week, I'm in the clinic at 8 and we're done around 5. We've got guest lecturers quite often at this point from around the field and other specialties that happen once a week. It's about a 2-hour lecture. We do a lot of literature review, which time in clinic or in the building is about 4 hours a week for that. Well, 3 hours a week just for that. And then obviously our research takes up about a day a week. So around 3 days a week, I'm in the clinic seeing patients. Our clinic is full all the time. So I'd say mostly I'm seeing cases. We see about, they say the minimum to graduate is about 250 root canal treatments finished, which is on the low end, not on the low end, it's on the high end for universities. It's University of Iowa is a powerhouse when it comes to clinical experience. I would venture to say I'll probably graduate with 400 cases. And that's finished cases. I'll probably see 1,000 plus patients and start treatments on 1,000 plus cases before I graduate.
So Bob, I had a question on kind of the research environment that you are in. So I work in a cancer research lab, but really my lab, if you were to look at it versus the lab across the hall, it would look almost identical. And looking at some of the equipment that you had in your lab, it seems very specialized, and it would be, expensive equipment for any one lab to house. So, is that shared space that, multiple, research entities are utilizing? I guess how much collaboration is there within that?
So as of right now, as far as I know, just the physical therapy program is using this space. And specifically, it is specialized, and Dr. Wilkin, who is on, may be able to shine more light on that. But it is very unique, and for the most part, it's just the physical therapy program using this.
Okay.
So I had a question for both of you. I'm really interested. I know for you, Bob, that your work is now not as much. It's on the research side, so you're not working with patients in the same way. But I'm fascinated about what do patients most resist in your profession? What are the things that you find folks bucking up against when you're trying to help them and treat them?
So I guess the first thing that comes to mind for me is that they resist putting ownership of their treatment on themselves. So what I mean is that for physical therapy, somebody might spend maybe 10, 12, maybe only 4 or 6 visits in a clinic. And a lot of times they come in with the expectation that the doc, the physical therapist, is going to be the one to fix them. What they don't know is that that is a very minimal amount of time in the clinic, where the other 23 hours a day, 5 days a week, that they're continuing to overwork their muscles or not use them properly or put wear and tear on their joints, needs to be done on their own time. And they need to take the ownership themselves to help fix themselves. And what the physical therapist is really there to do is to educate them on different exercises and techniques that they'll be able to use outside of the clinic when they're on their own time, so that they can get a full recovery.
Chelsea, do you mind asking the question one more time?
Yeah, so I was wondering what patients most resist in your practice. Like, I have 100% a different experience. I was teaching literature for a long time, and I know that when my students were writing essays, the thing that they resisted the most was editing. They thought that if they wrote it, then that is good, they are golden. So thinking about folks from that perspective, I was just really curious about, like, what do people just not want to do when you're trying to help them?
Well, when they come to me specifically, they're probably in pain. You know, for the most part, no one wants a root canal unless they absolutely need it. So getting them in the chair is actually incredibly easy. Other aspects of dentistry, it's very hard to get a patient in the chair sometimes because they don't see a perceived need. But for the most part, people have a perceived need when they come to me. The hard part is to get them to come back for follow-up care. You know, getting someone out of pain is motivation. And once they're out of pain, even if I'm not finished with treatment completely, you know, I might have addressed the source of infection, but I didn't place permanent restoration or get them referred yet to the right provider to build that tooth back up. We lose a lot of people to finishing their care.
So to follow up just slightly on that question, I think I already know the answer to this, but who were the better patients, the soldiers or the dogs?
Well, I mean, come on, yeah, the dogs were great. They were sedated too, though. Yeah. So that's kind of a cheat code, right? You know, you sedate something and they become the best patient possible. Yeah, I will say the biggest soldiers with the most tattoos were the ones that hated getting anesthesia more than anybody else. It was always the funniest thing.
It is funny. Bob, Jessica has a question for you. She says, I'm glad to hear you're passionate about teaching. The materials and equipment y'all are using to monitor seems extraordinary. How many patients are you able to see with this type of technology on a regular basis?
So really the technology and equipment that we're using right now is primarily for research. We're not really using it for patient care. And with the research, we hope to be able to bring different aspects of the research into the clinical practice, where physical therapists around the country would be able to use similar technology, but maybe using their cell phone or an iPad or just a video camera set up in their clinic for doing the same type of visual feedback, which will help benefit them and have a larger impact than somebody just affording this extraordinary amount of research and technology.
Yeah, that was something I was curious about too, is like where care and research overlap in your work. So how much of your research focuses on people who would need, you know, the both like the different imaging and that kind of thing in order to provide care, or do you do your research with folks who like wouldn't need that, if that makes sense? Sorry.
So we get a wide variety. We have patients that have significant injuries that are coming in for the research, and they're also going to physical therapy on the outside, whether it's at the university or some other clinic. And then we also collect information on healthy, regular people that do not have injuries or haven't suffered traumatic events.
That helps. Thank you.
I see a question. Sarah Sullivan asked me directly. I don't think everyone else is going to be able to see that. But youngest patient to oldest patient I've seen, and then the commonalities and differences between the two. Youngest can be as young as 7 years old, 8 years old when you're, I mean, really it could be earlier than that, but for the most part, I won't be doing root canals on a primary tooth. We'll be doing them on permanent dentition. So the first teeth that you'll get are your central incisors that are about 7 years old. But for the most part, I won't see those unless they're sedated in the pediatric department. And oldest can go all the way up into geriatric, late life stage, 90s plus. I've seen a 95-year-old gentleman that was great. The difference between the two, throughout life, the nerve, the pulp space of a tooth narrows. You have continued deposition of dentin, which is the main bulk material of your tooth, and it will continue to shrink over time just by normal wear and tear, by the occlusal forces of your teeth, cause a stimulation of dentinoblasts in that area and shrink more and more. So elderly individuals and people with bruxism issues, like that grind their teeth a lot, you'll see really small spaces, and that just makes it way harder for me to get anything down it. And that's where you're going to see a lot of your separations of files. Children and very young teeth that are really wide open are in a different type of difficulty in having enough tooth structure there to have strength. Because if it's completely hollowed out and there's not much there, if we stop the development process by doing a root canal and killing all the cells in there, you're weakening the tooth or leaving it weak. So we're constantly looking for better ways to place materials that might help regeneration, or what we call apexogenesis, where the apex of the tooth can still continue to form and merge. So yeah, very different treatments depending on if you have an open apex of the tooth, the tip of the tooth, or a closed one. So yeah.
So to, I guess, partly address one of the questions in the chat, we would have loved for this semester to do things face to face, but unfortunately, none of the circumstances we couldn't do that. Hopefully, this coming fall we'll be able to do this in person. But with that, how has this pandemic kind of affected your ability to function in the workplace and your research?
You're asking about COVID specifically?
Yeah, that pandemic. Yeah.
Yeah. Sorry. Yeah, that one. Yeah. It definitely slowed us down initially. I wasn't here though, yet in last March, but the clinic shut down for a couple of months. But since then, really the focus has been on barriers and PPE, extensive PPE. I mean, if you guys are back in your dental offices getting your cleanings done, you'll notice increased masks, increased suctions in the room. So for us, that was a very quick thing to move to, because in an urgent care setting like we are, you just can't not see people. If they have swellings or pain, you can't wait 6 months on that. So for the most part, we've been full bore since I got here in July.
And here like Ryan, also, I was not here in March of last year when the pandemic kicked off. I know that it put a all hold stop on research and in-person activities like that here at the university, including in this lab. Since July, August, we've been able to collect some research on some subjects. I can't remember exactly when we started back up. I think it was maybe in October, but it's been kind of slow. So here ramping up this spring, it's ramped up quite a bit and we're collecting more and more research. But like what Ryan was saying, we're taking all the precautions, using PPE, the masks, shields if we need to, wiping everything down with sanitizing wipes and making sure everything is good and clean, that kind of stuff.
Well, I hope that things continue in a positive direction and we can all kind of get back to some normalcy and no more research slowdowns or shutdowns.
Are there any final questions that folks want to ask either Bob or Ryan?
I just want to say thank you to Chelsea and Jacob so much for putting on this series on. This is an awesome venture that you guys are doing. So, really appreciate it.
Thank you for being a part of it. Yeah, all of you. Oh, Sarah has one more question. Sarah wanted to ask, were you just asking me personally? No. Sarah wanted to know, Bob, if you coordinate with sports medicine at all with your research or practice.
So yeah, the sports medicine clinic for the University of Iowa, I imagine what you're referring to. So they have sort of their own line of research kind of stuff that they do, but we do coordinate. We are familiar with them. And sometimes we have subjects or participants in common.
Awesome. I think I froze there for a second, so I'm sorry. Well, again, thank you so much to both of you for sharing your experiences with us today. And thank you everyone who came. It was wonderful to see your faces and to get to hear your questions and the responses. This will also be available, the recording, on our website. So if you think of someone who would have loved to be here, feel free to let them know that it will be on our website tomorrow to share with them. We're at veterans.uiowa.edu. So with that, we'll say goodbye.
Thank you, everyone.